Hi, I'm Peter Boland, and welcome to More Health, Less Healthcare. Today, I want to start with a simple but uncomfortable idea that the US doesn't have a shortage of medical care, it has a shortage of health. We spend more on healthcare than any other country in the world, yet, if you look at the outcomes, whether it's life expectancy, chronic disease, or maternal health, we keep falling short year after year. And at some point, that stops being a data problem, stops being about measurement or access alone. It becomes a design problem. And that's what this series is all about. I'm calling it More Health, Less Healthcare. And the goal is to take seriously the idea that what we've built isn't really a system designed to produce health. It's a system designed to respond to sickness. So the question underneath everything we'll talk about is this: what would it look like to actually build an economy of health, not just a delivery system for illness? And to answer that, I want to start in a place where the stakes are immediate, human, and pretty hard to ignore, and that's maternal health. Because if you want to understand what a system truly values, we as a society, what do we value the most? You look at what happens at the beginning of life. Maternal health is one of the clearest mirrors we have of our values. And it shows us in real time whether we're willing to invest early, invest consistently, and invest in the conditions that actually create health, or whether we're more comfortable stepping in later when something has already gone wrong. And if we're serious about health as an outcome, maternal health would be one of the safest, most obvious investments we could possibly make. We know what works. Stable housing matters, access to nutritious food matters, consistent, respectful, and safe maternity care matters, mental health support matters, reliable primary care matters. We know what the causes of poor maternal health are, and we know what the answers are, the solutions are to fix it. None of this is mysterious. None of it's particularly controversial. Yet, when you look at how we actually finance and organize care, many of these things are treated as optional, preferable, nice to haves. At the same time, we pay, and generously, for complications, for emergency interventions, NICU stays, for the most expensive moments after risk has already turned into harm. So we end up with a pattern that feels familiar. We say maternal health is a priority. We publish reports, we launch initiatives, but underneath that, the structure stays the same. Benefit designs, revenue models, and day-to-day operations all continue to treat mothers less as a central investment and more as a cost to be managed. And that gap between what we say and what we actually build is where a lot of the problem lies. And this is also where my work comes into play, because I tend to start from a pretty basic observation. If a system makes money from illness, it's never going to have a natural incentive to keep people well. It can try, it can run pilots, we can talk about prevention, equity, even whole person care. But unless the underlying business model changes, there's always going to be a kind of gravitational pull back towards utilization and more sickness care. More visits, more procedures, more interventions, not necessarily more health. So maternal health is where that tension becomes really hard to ignore because the stakes are so clear. Health plans and delivery systems know that poor maternal outcomes are expensive, terribly expensive. They know the reputational risk is real. They know the racial inequities in maternal health are unacceptable. They also know, and this is important, that early, continuous support works better than waiting for something to go wrong. And still, in many cases, our response is slow. Program stay small, pilots stay small, more investments stay cautious. Maternal health gets treated as something adjacent to the core business instead of something that defines whether the system is working at all. So I want to be clear about something here. This isn't about blaming clinicians. It's not about blaming nurses and midwives and doulas and frontline staff. In many cases, they're doing extraordinary work, but inside constraints that they don't control. So what I'm really interested in here is what are the structures that leaders do control? Things like how benefits are designed, how payment models work, what gets measured and what doesn't, how networks are built, how organizations partner with local communities, and how risk is distributed between institutions and families. Maternal health gives us a very concrete way to examine these choices. So let's ask a bigger question. Are we actually building a system that creates health? Or are we continuing to refine a system that manages sickness? I want to contend we need both, but we haven't focused on how do you build more health. And that's what the series on maternal health is going to explore. Over the next few episodes, I'll use maternal health as a way to look at incentives, policy decisions, leadership behavior. Do they reinforce the system we have, or start to move us towards something different? In the first place is what I think of as, well, the first piece I want to talk about is the hidden tax on motherhood. That's right, there's a tax on motherhood. Maybe we don't see it as such, but there is a tax on motherhood. Because even before we talk about reform or design, redesign, it's important to understand that costs already exist. Those costs are visible. Medical bills, lost wages, medical debt, but a lot of them aren't visible. They show up as risk, as uncertainty, and the stress that families carry when they're not sure if support's going to be there when they really need it. They show up in the moments where care is delayed or fragmented or treated as reactive, instead of continuous. One of the arguments that I'll make is that this tax isn't accidental. It's just not bad luck or an isolated failure. It's the predictable result of how we design coverage, how we structure benefits, and how we assign accountability. Then I want to turn to policy and payment, because if we look honestly at where the money goes, we see something pretty striking. We're good at paying for high-cost episodes. We'll cover a prolonged NICU stay and we'll pay for emergency interventions. We'll absorb the cost of complications that, in many cases, could have been reduced or avoided altogether. But we're much less consistent about investing in the conditions that prevent those outcomes in the first place. So part of this series, we're going to look at the levers that actually shape behavior. Benefit design and rate setting, performance measures, even contract structures, not in the abstract, but in terms of how they lock in the status quo or begin to dismantle it. And then finally, I want to talk about stewardship and implementation, because even when the path forward is clear, execution is where things too often break down. So what does that actually mean? For leadership, executives, boards, management teams, to treat maternal health as a core responsibility, not as a side initiative, not as a charitable effort, but something that belongs on the balance sheet itself, as something that reflects whether and an organization is managing risk well, or just reacting to it? Or do you just move from pilot to durable practice? How do you build real accountability with local communities? And that raises questions, critical questions like, how do you align internal incentives? What are the outcomes you say you really care about? These aren't small questions, they're necessary ones. It's a difficult conversation to have. But ultimately, the series isn't just about maternal health. Maternal health is the lens. The larger subject is the structure of American healthcare itself. If we can't align incentives, benefits, and daily operations around something as fundamental and as widely supported as the health of mothers and infants, then it's pretty hard to argue that we're going to be serious about health anywhere else. What matters, what really interests me most is what happens when we stop treating poor outcomes as inevitable, when we stop framing them as unfortunate but expected, and instead we start seeing them for what they often are, the logical result of the systems we've built. Systems can be changed, and maternal health gives us a place to do that work in a very, very concrete way. It shows us where we're still relying on sickness revenue, where we're delaying investment in prevention, and where there's actually an opportunity to lead differently. So this is really an invitation to look closely at one of the critical areas of care and how to use it to see the broader choice in front of us. We can keep optimizing the system built around sickness, or we can start deliberately to build something else, an economy of health. So thank you for listening. We're going to go much deeply into this next 2 episodes. Again, Peter Boland, thank you for listening.